All right, thanks so much for joining us. I'm Kendra Sweet from Moffitt Cancer Center in Tampa, Florida. We are going to be talking about the clinical data that supports each treatment milestone in chronic myeloid leukemia. The Philadelphia chromosome defines chronic myeloid leukemia. The BCR region, or the reciprocal translocation between the BCR region on chromosome 22 and the ABL region on chromosome 9 forms the fusion gene BCR-ABL. BCR-ABL then distributes throughout the cytoplasm, causing a constitutive tyrosine kinase activity. This resultant tyrosine kinase activity leads to autophosphorylation and activation of multiple downstream signaling pathways that impact gene transcription, apoptosis, skeletal organization, and the degradation of inhibitory pathways. Treatment for CML includes ABL tyrosine kinase inhibitors, which have proven to be highly successful at blocking BCR-ABL and ultimately restoring normal hematopoiesis. This is an old slide, but I like to show it because it really nicely depicts the improvements that we've seen in survival in early chronic phase CML patients over the course of many decades. The top curve defines the TKI era since the development of imatinib, which was the first ABL tyrosine kinase inhibitor to gain regulatory approval. There are two guideline committees that have established guidelines that clinicians typically use to help guide their treatment decisions and assess response to patients' treatment on TKI therapy. The National Comprehensive Cancer Network, or the NCCN, is comprised of numerous sites around the United States. The European Leukemia Network, or the ELN, is made up of a number of experts in Europe and other parts of the world. Both guideline committees have established response milestones that patients are desired to meet at various time points during their treatment. Both the NCCN and the ELN response milestones are fairly well aligned at each evaluable time point. So this slide shows the NCCN response milestones at 3, 6, and 12 months. Each color in this top table corresponds to the degree of clinical concern that should arise dependent on the patient's response at each time point. So each response milestone is based on the PCR analysis, measuring the BCR-ABL transcript level that's reported on the international scale. So at 3 months, the desired response is a BCR-ABL transcript level less than 10%. In some cases, a value greater than 10% may be acceptable, but in general, the desired response is a BCR-ABL transcript level less than 10%. By 6 months, ideally, BCR-ABL transcript will be less than 1%, but as you can see, as long as the transcripts are less than 10%, these patients are considered to be meeting their milestones. By 12 months, the desired response is really dependent on the patient's individual treatment goals. So as long as the BCR-ABL transcripts are less than 1%, which is considered equivalent to a complete cytogenetic response, this is considered successful treatment. However, the ideal response is a major molecular response, which is a BCR-ABL transcript level less than 0.1%. This value of 0.1% is more pertinent to a patient who has a long-term goal of achieving a treatment-free remission. But when we talk strictly about which response correlates best with overall survival, it's this value of less than 1% that's the more meaningful response. The ELN response milestones are categorized as either optimal, warning, or failure, depending on the values at each time point. The optimal responses are pretty similar to the NCCN, but are perhaps a little bit more stringent, where you can see, for example, at 6 months, the ELN has a response goal of less than 1%, but they don't consider values between 1 and 10% as failure. That would be considered a warning response. Similar to the NCCN, their ideal response at any time is a major molecular response or transcripts less than 0.1%. But the ELN also has a disclaimer, as you can see here at the bottom, where for patients who have a future goal of achieving treatment-free remission, their optimal response is different. And this is because major molecular response does not qualify someone for an attempt at TKI cessation. So if someone has an ultimate goal of TKI cessation and attempting TFR, in those patients, the optimal response at any time is a BCR-ABL transcript level less than 0.01% or MR 4.0. So the next question is, where do these recommendations for these guidelines come from, and what's the clinical data to back up these guidelines? So I'm going to start with the 3-month data and move forward from there. And the most impactful data to support this early molecular response, or EMR, comes from David Marin and colleagues at the Hammersmith Hospital. Here they looked at 282 chronic phase patients who were treated with imatinib, and they looked at the BCR-ABL transcript level cutoffs at various cutoffs at 3, 6, and 12 months to identify which cutoffs were most significantly predictive of overall survival, progression-free survival, and failure-free survival. They used highly sophisticated statistical methods to classify patients as either high risk or low risk with maximal sensitivity and specificity. And what they found was that patients who had BCR-ABL transcripts less than 9.84% at 3 months had a significantly higher 8-year overall survival than those patients whose transcript levels were greater than 9.84% at 3 months. This cutoff strongly predicted for all of the other outcomes as well, but given that overall survival was the most relevant outcome, this cutoff is what was used for their transcript-based predictive system. And this has now been simplified to just 10% at 3 months. The German CML4 study looked at the impact of early molecular response on long-term outcomes as well and found similar data, where you can see with this curve here on the right, patients who had BCR-ABL transcripts greater than 10% at 3 months had a significantly worse 5-year overall survival than those who had transcript levels less than 10% at this time point. When they then looked at the difference in patient survival, if they had transcripts between 1 and 10% at 3 months or less than 1% at 3 months, there was no significant difference in survival. So this data backs up the guidelines that are put out by the ELN and the NCCN, suggesting that this EMR at 3 months is an important treatment milestone. In the frontline studies looking at second-generation TKIs compared to imatinib, they also looked at the impact of early molecular response at 3 months. And again, we're able to support what was seen previously, in that there is a significant advantage to achieving early molecular response at 3 months. But what was more important, in my opinion, from these studies was not so much that they could, again, validate that data, but rather that the advantage that was seen from achieving an early molecular response was seen regardless of which TKI a patient was being treated with. So whether these patients were on imatinib or a second-generation TKI, the beneficial impact of achieving early molecular response was the same, with few exceptions. The difference lies in the number of patients who achieve early molecular response. There were a higher number of patients achieving this response if they were treated with a second-generation TKI as frontline therapy compared to imatinib, but once they achieve that response, the advantages were the same. The INEST-ND trial, which was the phase 3 trial that compared nilotinib to imatinib in previously untreated chronic phase CML patients, looked at the outcomes in patients who failed to achieve EMR at 3 months. And they found that more than half of patients ultimately achieved BCR-ABL transcripts less than 10% by 6 months. However, in the patients who did not go on to quickly lower their molecular values, there were a number of them who actually progressed to advanced phase CML, many of whom did so between months 3 and 6. And this fact is actually concerning when you think about continuing treatment after failing to achieve EMR, because it does raise the risk of losing a patient to progression before that 6-month response assessment. Obviously, there are people who don't necessarily agree with that last statement, and there is actually a significant body of evidence that suggests the 6-month assessment may be a better predictor of outcomes. So this paper was published by the group at MD Anderson, where they looked at 456 patients, and here they used major cytogenetic response as a surrogate to a PCR value of less than 10%. And they found that of the 456 patients, only 44 of them did not achieve major cytogenetic response at 3 months. Of those patients, 43% ultimately achieved this response by 6 months. When they then analyzed how these different groups fared as far as overall survival, transformation-free survival, and failure-free survival, there was no difference between the two groups of patients in any of those 3 categories. And the only patients who fared worse were those patients who still did not achieve a major cytogenetic response by 6 months. So what this tells us is really, I think we need to take a lot of this data into some sort of clinical context, because if we have a patient who at 3 months has had a number of dose holds or dose reductions because of side effects or cytopenias, or even if their BCR-ABL transcripts are just barely above 10%, if someone's at 11% or 13%, that may be someone that we can feel comfortable saying, this person can wait until their 6-month assessment before we really use this data as something that can be predictive of outcomes. And not all patients need that 3-month assessment to truly predict their long-term outcomes, because in some cases that 6-month outcome is a better predictor of response, long-term response. Susan Branford and colleagues reported similar data where they looked at 528 chronic phase patients treated with imatinib, and then looked at those patients who failed to achieve BCR-ABL transcripts less than 10% at 3 months. And they found in that group of patients, only 4% of them progressed before their 6-month evaluation. And in that group of patients, again, the only ones who did worse in regard to overall survival, progression-free survival, or failure-free survival were those who had BCR-ABL transcripts still greater than 10% by their 6-month evaluation. As long as their transcripts were less than 10% by 6 months, their responses, their survival overall was the same as the patients who had an early molecular response at 3 months. So again, this data supports the guidelines both by the NCCN and the ELN, stating that as long as transcripts are between 1 and 10% at 6 months, the patient is not failing treatment. Dr. Branford went further with her study to look at the impact of early molecular response on the ability to achieve a major molecular response in the future. She found that in patients who had transcripts greater than 10% at 3 months, but then achieved transcripts less than 1% by 6 months, their rate of MMR was the same as those patients who had transcripts less than 10% at 3 months, again suggesting that perhaps the 6-month time point is more predictive than the 3-month assessment. But going back to the initial David Marin study, they found that the cutoff of less than 1.67% at 6 months was also highly predictive of overall survival. So they went back in a later study to look at the impact of patients who achieved their 3-month milestone of less than 10% and the 6-month cutoff of less than 1.67%, and then looked at the differences in patients who were high at 3 months, but low at 6 months, or low at both time points, or high at both time points, and all the various combinations. And what they found was patients who had low levels at 3 months and high levels at 6 months had identical overall survival and progression-free survival to those who were low at both time points, but the kinetics of their response was slower. But in patients who failed at 3 months and had lower levels at 6 months, they had significantly worse outcomes in regard to overall survival, cumulative incidence of complete cytogenetic response, and cumulative incidence of MR 4.5, suggesting that we're not able to rescue patients by achieving deeper responses at 6 months if they failed to achieve a good response at 3 months. So if I've thoroughly confused you at this point, I'm not surprised, because the data surrounding the 6-month assessment is really quite conflicting. But in spite of this point of contention, what's abundantly clear is that if transcript levels are greater than 10% at 6 months, this is associated with inferior outcomes, and this is considered treatment failure. Essentially, all of the available data will support this fact, as well as the NCCN and the ELN guidelines. So we'll move on now to a more clear-cut data point, which is the impact of complete cytogenetic response at 12 months. CYR is equivalent to a BCR-ABL transcript level of 1% on the international scale, and both the ELN and the NCCN recommend that 1% at 12 months is the desired response as a minimal response at that time point. And this is because we have data that tells us that there is a significant survival advantage, both event-free survival and overall survival, for patients who achieve CCYR by 12 months. So this was a retrospective review of 435 patients with chronic phase CML, and you can see the top curve here on the right is event-free survival, the lower curve is overall survival. And at 3 years, there is a significant survival advantage, again, in patients who achieve CCYR by 12 months. So the 3-year event-free survival is 98% in patients achieving this response at 12 months versus just 67% in patients who did not achieve a complete cytogenetic response at 12 months. Looking at overall survival, the 3-year OS was 99% for patients who achieved CCYR by a year versus 94% in patients who did not have a complete cytogenetic response by a year. But what about major molecular response? Both guideline committees say that this is the ideal response at a year, in spite of the fact that we know that CCYR is what correlates best with overall survival. So is there truly a long-term advantage to achieving major molecular response at a year? What we know is that major molecular response is associated with a durable long-term cytogenetic remission, as well as a lower rate of disease progression. So looking at the IRIS trial, which was the randomized phase 3 trial of imatinib versus interferon and low-dose cytarabine, in patients who had achieved a major molecular response by 18 months, they had a 3% probability of losing complete cytogenetic response by 7 years. This is in comparison to 26% probability of losing CCYR by 7 years in patients who had complete cytogenetic response by 18 months, but not MMR. There was no progression to advanced phase CML in the patients who had MMR by 18 months. So that's where they found the benefit of MMR. When looking at the event-free survival, there was no difference in event-free survival at 7 years in patients who had achieved MMR by 12 months versus those who had CCYR at 12 months, but not MMR. Where there was a significant decrease in the 7-year event-free survival was in the patients who had transcripts greater than 1% at 12 months, suggesting that they had not achieved a complete cytogenetic response. So really the true benefit of major molecular response at 12 months is in the increased durability of complete cytogenetic response, and this complete cytogenetic response correlates with progression-free and overall survival. So it's important to note that MMR does not predict for superior overall survival. In the German CML study 4, they found no significant difference in progression or overall survival between patients achieving CCYR and those achieving MMR. They did see a survival advantage in patients who had achieved a deep molecular response compared to those with a complete cytogenetic response. At this point, however, deep molecular response has not been incorporated into any of the guidelines as a response milestone. That may change in the future, but as it stands today, that's not a response milestone that has been put out there by the ELN or the NCCN, but there is a survival advantage compared to those who don't achieve a complete cytogenetic response. Therefore, in the absence of MMR in patients who have achieved a complete cytogenetic response, this lack of MMR is not considered treatment failure by the NCCN or the ELN. Oftentimes I get asked what I do in the clinical setting in a patient whose BCR-ABL transcripts plateau at a value between 0.1 and 1%. Do I change treatment? Am I comfortable leaving them there? What do I do in that clinical setting? And quite honestly, it depends on the patient. It depends on their goals. It depends on their current treatment. I think generally speaking, if the patient's being treated with imatinib and their transcripts plateau in that range, I very likely will switch them to a second generation TKI after a discussion with the patient in an attempt to try to deepen their molecular response. But if that patient's already on a second generation drug, it's unlikely that I'm going to change their treatment. And this is because in the absence of a mutation or in the absence of any significant compliance issues, I don't truly believe that switching from one second generation TKI to another second generation TKI is going to result in a significant change in their molecular response. Perhaps switching to ponatinib, which is a third generation TKI, will result in a deepening of their molecular response, but I don't think that we can justify the potential risks of ponatinib therapy in this setting as long as we can assure that the patient has achieved a complete cytogenetic response. I don't think that the value of achieving major molecular response justifies the potential risks of ponatinib therapy. So again, it really is dependent on the patient. It's dependent on their current therapy, whether or not I would make a change in treatment. So I just want to finish with a brief statement on predictors of deep molecular response, because as I said, we really have to do some extrapolation of data to try to correlate major molecular response with overall survival. But we do have data that tells us that patients who achieve major molecular response by 6 months have a higher likelihood of achieving, a significantly higher likelihood of achieving a deep molecular response in the future. And durable deep molecular responses are required in order to make an attempt at TKI cessation. So with treatment-free remission becoming more of an attractive goal for many of our CML patients, the value of this early major molecular response is increased. So the long-term goals for our patients need to be considered when we're making those frontline treatment decisions, because the impact of that frontline treatment decision can impact the likelihood of an early major molecular response, which could impact the likelihood of achieving a deep molecular response, which impacts the likelihood of being able to attempt TKI cessation and ultimately achieving a treatment-free remission down the line. Thank you so much for your time, and please feel free to contact me if you have any questions.